Welcome to the Ortho Joe podcast, a joint production of the Journal of Bone and Joint Surgery and Ortho Evidence. Join hosts Mohit Bhandari and Marc Swankowski as they discuss current topics and publications in the world of orthopedics and beyond.
Welcome, Marc. How are you? To another exciting episode of Ortho Joe. I have a mug. It's in the afternoon. I'm grabbing a little bit of Java right now. It's pretty good.
Well, we have a winter storm warning in Minnesota, so I've got the proper English black tea going here, just to stay warm, before shoveling, I think, tomorrow morning. But
I get you. Well, listen, we have, in my mind, a superbly thoughtful, insightful, well-traveled individual in George Athwal with us today, professor of surgery at the Roth McFarlane Hand and Upper Limb Center in Ontario, Canada, at Western University. George, I would easily consider you to be one of the, in my mind anyway, one of the top minds in hand and upper limb, and you've done a lot, in the area. But today, I guess Marc and myself were hoping that you might be able to give us your take and your thoughts on, reverse total shoulder arthroplasty, and specifically, how and why it's become such a popular treatment choice. And I'm curious if, in fact, is the pendulum where it needs to go? Is it going to go further in that direction? Just getting your insights on this pretty impressive innovation that's probably, now, 60, 70 years old in terms of at least various counts of when it was modernized. But I certainly am curious in your take, and maybe I'll start off with one statement, and I'll get your take on this. I think in the Journal of Shoulder and Elbow Surgery in the May 2021 issue, there was a paper that looked at sort of the incidence, and it kind of ended off with basically saying that the incidence of primary reverse total shoulder arthroplasty has substantially been increasing over the last decade or so. And I wonder if you might just enlighten us as to why.
Well, first of all, thank you for that wonderful introduction. I feel a little bit out of place in that I don't have a coffee. I guess I should, when I heard the Java Joe, I probably should have had a coffee right. Marc, you got to eat, so I'm not sure if that counts either.
No, it doesn't.
Yeah. So, looking at shoulder arthroplasty in general, I think it's come a lot down to education. I think our primary care physicians now understand that there is shoulder replacements. I still have a large majority of my patients that come in with a diagnosis of osteoarthritis. They still can't believe that shoulder replacements exist. They're very familiar with hip replacements and knee replacements, and believe it or not, shoulder replacements are still relatively new in the general public's eye. So I think once the primary care physicians have been educated and it's been done very well, I think they're indicating patients and referring patients on for management of shoulder arthritis. So certainly the incidence is increasing.
Oh, that's superb. So when you go back then, just historically, how far back does at least the concept of reverse total shoulder arthroplasty go? And when did it really functionally gain like a modern style, prosthesis?
Yeah, that's a really good question. I think if you look far enough, there's these reverse articulation designs or these constrained designs have been 50, 60, 70 years. But really it was Paul Gramont, a French surgeon, who kind of experimented with several different reverse designs and is really considered the grandfather of modern day reverse shoulder arthroplasty. And he kind of popularized this in France. He did have some challenges. I think there were many more poor designs and failed designs and potentially patients that were harmed before he mastered the final design, which is now very similar to what we're using now. And then Marc Frankel from Florida kind of revolutionized, I really consider the grandfather of American reverse shoulder arthroplasty, kind of revolutionized the concept of lateralization. And now the Europeans are kind of following that philosophy. So there was the first, which was Paul Gramont, and like Marc Frankel has kind of brought that along.
Yeah, George, why is it that there's so many more being done than anatomic shoulder replacement? The traditional total shoulder arthroplasty with replacing the glenoid, et cetera. What is that about?
It's interesting. If you look at just even primary glenohumeral joint arthritis, the more we've learned about it, initially we would indicate every patient for a primary anatomic shoulder replacement. And that we found is that certain patients with certain types of glenoid morphologies just don't do well with a regular shoulder replacement, they have a higher incidence of loosening or revision. So excessively retroverted glenoids, patients with bone loss. And so our indications have become much better with primary anatomic. And the unique thing is that those patients that may not be a good candidate for an anatomic end up being a very good candidate for reverse. The reverse arthroplasty with its constrained design has unbelievable indications. So we can indicate it for patients with bone loss, revision cases, tumor patients, fracture patients, post-traumatic sequelae. Its ability to manage all of those patients is truly unbelievable. It revolutionized our management of complex shoulder problems.
I was just going to follow up. Is it just easier than an anatomic shoulder replacement?
Well, I mean, there's probably it's multiple things. One thing is just we don't really need the rotator cuff with reverse shoulder arthroplasty. The rotator cuff is helpful. It helps with rotation with a reverse. But with an anatomic shoulder replacement, you need the rotator cuff to get your arm up in there. Because it's a non-constrained joint. And the other thing is you need stability. You need the implants to be in anatomic position. And so in cases of bone loss, we really can't do that with an anatomic. And the reverse picks up where the anatomic left off. It doesn't truly need the rotator cuff. We can get great fixation in the glenoid with metal. So those indications are kind of looped in reverse. And technically, you never want to use the word, it's a forgiving operation, but some people would use that word to describe it. It's actually potentially probably a little bit easier to get right than it is with an anatomic, which requires some bony work and some soft tissue balancing.
I mean, would there be, George, a learning curve? I mean, has there been work done on, well, you need to do a couple of things. I mean, how many do you need to be doing to stay competent and quote expert, I guess? And is there a relative, curve up?
Well, it's interesting. So when I first started doing reverse shoulder arthroplasty in 2005, we actually didn't know a lot about it. And when I was doing my reverses, I was doing them with the same mindset as an anatomic. And we started to learn from our European colleagues that we actually had to put them in tighter. So we had actually, when we first looked at our reverses, we had a high complication rate and the learning curve was long. And so the advantage of modern day surgeons now is they learn from our mistakes and they learn from the mistakes of European surgeons. And so now the learning curve has substantially decreased. Our indications have increased and the learning curve has decreased. So all those growing pains we have are no longer experienced by the young modern day surgeons. And what is the magic number to do a year? It's a really good question. I think the average American surgeon maybe does under 10 or 15. But I would say if you're doing 15 or 20 a year and you're going to CME courses and you're staying up to date in the literature and the techniques, I think a reverse shoulder arthroplasty should be in your wheelhouse.
That's actually fascinating.
George, I spent my 10 years as editor-in-chief of the journal and have now passed it on to somebody much smarter and more innovative than I, waiting for the article of 70, 100, 150 failures of reverse shoulders and the issues with revision of a failed reverse shoulder, and it just never showed up. Is it coming? Are you required to revise a lot of these that are perhaps done by inexperienced surgeons?
So it's interesting when we look at companies and the way we think about arthroplasty, we want to make things last forever, or we want to make them last 25 years. And actually, when I do look at my own revision patient population, anywhere from 60 to 75% of them are early failures, probably due to a technical issue. And usually we can identify that technical issue. It's, implant positioning, instability, things that probably could have been made better. And so that's why I think one of the most important things that we should focus in on is education. If we can educate surgeons on how to put them in well, I think then we can start focusing on the 25 or 30-year-old reverse shoulder arthroplasty. The revisions are coming, certainly. With reverse total shoulder arthroplasty, it seems like the humeral side may be an issue as they get further along in the survivability curves, versus with the anatomic tends to be more glenoid-sided issues. And then there are some devastating complications with reverse, which is scapular spine insufficiency fractures, which can be difficult to manage. We're working on techniques to decrease the incidence of that. And if they do occur, management techniques. I think there will be some papers coming out. I think the complication profile is a little bit different. The number one complication with an anatomic is, potentially loosening, rotator cuff tear, and instability, which may be better tolerated by the patient versus a complication of a coronal insufficiency fracture is really quite devastating with the patient.
Can you speak, George, a little bit to like how evidence accumulated in this particular innovation? You go back to the days, let's say of Marc Frankel, for example, when he has this idea. If you go back to, let's say, locking plates were, almost became so popular in use that surgeons said it's unethical. I have to use them, and we never saw trials until very, very late. How did this evolve? And I guess from your perspective, we look at the broad scope of the evidence, in your practice and what you've been using to guide you. Are you compelled by the evidence in this area?
I think one thing that we had that was very fortunate is that we had really conscientious shoulder scientists. And you've put me on the spot here because I didn't prepare for this podcast. And the three surgeons that come to mind, and I'm going to apologize because there's probably many more.
Sure.
The three surgeons that come to mind are Gilles Walsh, Pascal Boileau, and Marc Frankel, surgeons that actually tracked their outcomes from their first reverse and followed them prospectively and then reported their complications and their positive outcomes. And I think because of those three surgeon scientists, I think they kind of developed the body of evidence behind reverse shoulder arthroplasty. And that's why I feel very comfortable using a reverse shoulder arthroplasty on my patient, on a family member. I mean, it's fortunate that we have those surgeons out there that did that.
Yeah, I know, absolutely. But let's say now, if you're looking at it, in modern day, and, you go to a journal club and you see a large prospective report, you know how valuable it was to you to shape you. Trainees today say, oh, it's not randomized. Like, why are we comparing it against something else? I mean, has it become unethical? Are you seeing those trials? And if you are you happy with them? Do we need more research, I guess, is the bigger question.
It's a very good question. I think we still haven't come up with the optimal design for reverse shoulder arthroplasty. I think what's going to happen in the future is our reverse shoulder arthroplasty is going to become patient specific, meaning that in the indication for a cuff intact osteoarthritis, you may position your implants a certain way to optimize your outcome. In a person with cuff deficiency, you may place your base plate or somewhere else. So I think science still has to be done. I don't think we need the randomized prospective studies for certain indications. So for cuff deficiency, massive rotator cuff tears, we probably don't. But maybe for osteoarthritis with cuff intact, we do. And I think there are several studies starting or ongoing looking at that patient population and that indication.
Yeah, George, I had the great pleasure of being a good friend of Jim Roth, and your upper limb center has made huge advances in the care of so many diseases and injuries, and you yourself are highly esteemed and well published and well recognized globally. I just want to ask you the question of all of your academic work. What would you say is let's just say single manuscript that you think has impacted care above all the others?
Oh, wow. I thought you were going to ask easy questions and, preparing.
George has so many papers.
I know it's a tough ask.
One of Mo's papers. I'm going to tell you one paper that I'm particularly proud of, and I can't take credit for it. I was a co-author on it. Is my good friend Peter Lappner. He had this great idea of doing a randomized prospective study comparing different types of exposure for anatomic total shoulder arthroplasty, and him and I then started recruiting patients. And then we compared the osteotomy to the peel, and then the peel to the tenotomy. And it was really his idea. And I was very fortunate to be partnered with him. And so that's one of the papers our set of papers I'm most proud of. One was published in the Journal of Bone and Joint Surgery. Our first one was. So I think that's one of the ones I'm most proud of.
Huh. And what's the impact of that trial?
Well, it's interesting. So up until that trial, it was quite controversial on what type of exposure you would do for anatomic shoulder replacement. So some people really believed in the tenotomy, and some people believed that, no, we have to do this new osteotomy of the lesser tuberosity. What we found is that it doesn't really matter what exposure you do, as long as you do a good job repairing it and are meticulous about the repair at the end of the surgery. So it really validated whatever you do, just do it well.
Okay. Well, thanks for that contribution.
And you know what? And I'm going to take just a bit of a tangent. I know we're talking about reverse total shoulder arthroplasty, but I'm going to take a bit of a tangent here.
Have you ever taken a tangent before? I've never heard of
I know, I'm just going to take it, but I'm just going to ask because I think people probably want to know. I mean, you're highly prolific. I see you traveling a ton. You're very active. You're a busy surgeon. How do you decompress, George? Like, what do you do outside of your day-to-day work that gives you all of this energy, this creativity that you have to be just as good as you are in your work?
Well, I can tell I have several hobbies, and one of my favorite sayings is actually to diversify your mind. People talk about diversify your assets. I think diversifying your mind is so important. Things I enjoy doing. Actually, you and I have some very similar hobbies. We both love mountain biking, and I love doing that with my family. I actually really enjoy going to the gym after work, and I find that it's a really good decompression for me. And also, you get to meet people from different walks of life at the gym, and you develop a social network. And I also have hobbies. I love classic cars. So yeah.
So, I mean, you can't just say that without naming a classic car. You gotta.
Now I'm going to get a little nervous. I actually just this year was able to acquire my dream car.
Oh.
Yeah, I know. Are you ready? I don't even know if I should say. Can we bleep this out?
No. You got to tell us.
Well, it's a 1967 Shelby GT500. It's been a long time, and so it's got a 328 Police Interceptor motor in it, beautifully restored.
Wow.
Night mist blue, one of 2048 made. So those are things that I decompress. I mean, those are things I enjoy doing, and so I think it's really important to have. You hate to say, I don't want to ever use that word balance, but I think you have to have enjoyable outlets. I mean, we're all very focused surgeons, but that energy can also be focused in our hobbies. And so I mean, you and I both love downhill mountain biking, going around the country.
Yeah, we do.
I love wine. I think we can be good at many things.
Well, I got one question that is related to those comments, George. Is your family aware of the car?
So it's funny. My wife was a bit hesitant when I said, this car's come up. It's a once in a lifetime thing. And then when she saw it, she loves it. And
lucky man.
Well, it's funny. And I have 3 kids. My oldest son, who's 17, couldn't care less. He can't tell if it's a new car or an old car. And then my youngest 12-year-old, he'll be just standing in the garage and stare at it we'll walk home. I'll come home, open the garage door. He's staring at the car. And my wife's like, what are you doing? He's like, Mom, look. Like he just likes looking at it. It does smell. We've nicknamed it Jesse. It does smell like gas, just like an old carburetor. It's got 2 Holly 600 carburetors on it, which actually do smell up the garage pretty good.
And your neighbors are fine. It's a quiet car, I imagine, right? It's like, I mean, no one knows. It's probably electric. If I think, what's this fancy electric car he's got?
It's funny. It's got it's a 428, and it likes gas. That's my oldest doesn't like that. He doesn't like it's not a very environmentally conscious car.
Yeah.
I told him it's got no air conditioning. It's got
there you go. There you go.
Triangle.
You're balancing it. Oh, and this are you doing? You're doing this probably up and down, aren't you?
Absolutely.
Most kids don't know what this movement is. For us, it's like, oh yeah, window go up and down in the summer.
Well, most kids don't know you have to stick a key into the door to turn it.
That's right.
Unlock it, and then to lock it at the end, you got to do the thing, or to press the button to keep the door locked.
Oh, that is so awesome! Awesome. Well, I am now aware you have this car, so I am now absolutely expecting at your next journal club at McMaster to see you drive up in that. I can't wait.
I'm not sure it would make it there.
Well, listen, huge thank you, George, for doing this with us and appreciating that, that we kind of cold called you on this and we figured that you would be a perfect guest for us today. We'll look forward to having you back. And like I said, anytime you have something of interest you want to share with us and the orthopedic community at large, Ortho Joe is at home for you. By the way, you will be getting, and maybe, I'll let Marc tell you about, the guest, our guest gift.
Well, it's an unbelievable Ortho Joe travel mug that's probably equivalent in value to your new Shelby. And I just you have to guard them because they are stolen and sold on eBay quite frequently. So be careful.
I love it. It's gonna, you know what? I'm gonna get a picture of it in the car holder, in the cup holder that does not exist in my car. But
I love it. I love it. I love it. I love it. I love it.
That's
Listen,
AM radio, just AM.
you can just keep going. I love it. That's awesome. Well, listen, thank you very much, and we'll chat soon. Thanks again, George.
My pleasure.
Bye, George. Thanks very much.
Cheers. Take care.
Bye. Happy holidays.
You too.
Same to you.